afternoon, everyone. Thank you so much for joining us for the webinar today. This is the Data and Analytics Workstream Overview and Research Data Governance Primer. My name is Jessica Holsey with Addiction Policy Forum. We're part of NCHATS to help with stakeholder engagement, coordination, and translation for the center, and really excited to have so many folks join us today. I'm going to do quick introductions, but more information about our presenters and their bios is available on the NCHATS website, as well as the Addiction Policy Forum website. But in no particular order, I want to introduce Dr. Elizabeth Chen. She's the Interim Director of the Brown Center for Biomedical Informatics. Her research involves leveraging electronic health data along with health information and communications technology to support biomedical discovery and healthcare delivery. We also have Dr. Karen Crowley with us, the Manager of Health Data Science at the Brown Center for Biomedical Informatics as well. Her interests include healthcare data, computing, and technology, as well as organization dynamics and processes in support of learning health systems. We also have Dr. Richard Jones, who's the Director of Quantitative Science Program and Professor in the Department of Psychiatry and Human Behavior at Brown University. He's a co-lead of data analytics and study design of the NCHATS Data and Analytics Workstream. And we also have Dr. Ted Miller presenting today, who's Principal Research Scientist in the National Capital Region, the Pacific Institute for Research and Evaluation. He's an adjunct professor of the School of Public Health at Curtin University, and also a co-lead in health economics of the NCHATS Data and Analytics Workstream. A little bit.
Thanks for the introduction. So I'll get us started. So we'll be talking on behalf of the NCHATS Data and Analytics Workstream. So next slide. Just disclosures, the funding for NCHATS, and then we thought we'd give you a brief overview of NCHATS, particularly for those of you who may not be familiar. So NCHATS is the National Center for Health and Justice Integration for Suicide Prevention, and so it's a national NIMH funded research center meant to build information bridges between healthcare organizations and criminal legal systems to identify individuals at risk for suicide and connect them to care, evaluating both the clinical and cost effectiveness of suicide prevention practices in this context. We have more than 100 working partners, 30 investigators, and 50 institutions from across the country just working together toward the mission of NCHATS. There are 4 main projects currently. They're listed here. And we have just started to have some pilot projects. So we're a relatively new center, just a few years old. So we're happy to be here to kind of talk about some of the work that we're doing. Next slide. And so as part of NCHATS, there is an administrative core and there's also a methods core. And within the methods core, there are these work streams. And so what the work streams do are they provide support for the center signature projects, Exploratory, and more recently, Pilot Feasibility projects and other center functions. As a whole, the work streams provide methodological expertise and operational support to NCHATS. We facilitate think tanks, and we also provide consultation, mentorship, and training. And so on the left, you see there's actually 4 work streams. And so today, we'll be talking with you briefly about the data and analytics work stream. And so there's 3 components, as we've heard through the introductions: study design, health economics, and biomedical informatics. And what we thought we would do today is just give you a high-level overview of each of these kind of areas within this work stream, and then delve into a topic that we've picked for this year's webinar. So next slide, I'll hand it over to Rich to talk about study design.
Thank you, Liz. In the area of study design, the core can give assistance in planning and carrying out analyses that involve research collected data, clinically collected data, and we're especially interested in working with pilot projects and making sure they have a solid design and are adequately designed to address the intended questions. Some of the things that that might be relevant that we can provide assistance with is in planning trials, including pragmatic trials or more traditional randomized controlled trials, quasi-experimental designs, which are research projects that take into account natural experiments or involve an experimental treatment that's not fully randomized. We can help planning treatment allocation and for experimental therapeutics. And we can help you plan the sample size, that you're going to need in the form of power analyses for doing your randomized trials. And we also have expertise in advanced data analysis methods, including multi-level modeling, measurement development, measurement research, and we can find the right expertise for you to help if you have a qualitative design and analysis question. And these in general are relevant designs that can be useful using real-world data or experimental data to advance services and policy research. And with that, I'll turn it over to Ted.
Thanks, Rich. So in health economics, I'm going to take a little bit different tack than Rich did and tell you a little bit about some things. Some of the things that are relevant to the center are just looking at what the intervention costs. And sometimes, particularly in implementation research, cost can be an outcome, though one has to be very careful because there's an NIH guideline that says that NIH can't fund research that's directed at how to reduce the cost of a service. It has to have a clinical component to be funded by NIH. So it's, does this change in the service, which saves money, provide the same patient outcome is relevant, but can we rearrange the order that the patients are handled to flow more patients through in the same amount of time? Doesn't qualify. Economic evaluation is the other end of it. It's, okay, so we've got the intervention costs. What is it worth it? And that takes and divides the costs by some outcomes. So you get the cost per outcome. If the outcomes are also in dollars, it's called a cost benefit analysis. If they're not, you're allowed one thing that wasn't costed. So you may take the costs of the program minus the medical cost savings and divide by the number of suicide acts prevented. And that would be a cost effectiveness analysis. And one of the outcome measures that's frequently used in health economics is the uncosted outcome, is a quality adjusted life year lost, which is also called in the global burden of disease, a disability adjusted life year, or a DALY. And then you get the cost per DALY, or the cost per quality saved. And one thing that's important as you do health economics is whose perspective are you looking from? Is it society where everybody's costs and benefits count? Is it government? Is it the health center? Is it the patient? And sometimes you look at many of those perspectives. There's also the question of equity, who pays and who benefits. So if I'm evaluating a motorcycle helmet, it's really relevant that society gets a lot of benefit, but the motorcyclist pays, because that has to do with political acceptability. There's also the problem that you can't put a dollar value on everything readily. A good example is our lives, a broken leg. You can calculate the medical costs of the broken leg, the work costs. What about your quality of life costs? Economists have methods for doing that. We call them willingness to pay, but we do it by looking at what people actually pay for things like small gains and safety, and inferring what society would pay to reduce the probability of a death or an injury or anything like that across many people. Cost is also a very interesting regression variable. If you've got, we've prevented this many suicide deaths, this many hospitalizations for suicide acts, this many emergency department visits, and this many people who just were, had major depression but didn't attempt suicide. And you want to have all of those in one variable. If you look at the costs of each one, including the quality of life loss, you can have a regression variable that properly weights them. Now, sometimes that's not worth it, because sometimes the fatality cost, which is up around $10 million, can dominate that. But in something like suicide, the hospitalizations can take a fair chunk too. And so it can be very worth it. And with that, let me turn it back to Liz.
Great, thanks, Ted. So I'll just briefly talk about biomedical informatics as a discipline. So on the left, this is just a formal definition of field. It's interdisciplinary. We really take a lot of methods and theories and techniques from a variety of fields and look at how we can bring them together to effectively use data, information, and knowledge, all with the goal to improve human health. So a pretty broad definition, but what the graphic on the right tries to show is some of the methods and techniques that we deal with. And we think about a lot of these things these days within the context of what's called a learning health system. And so how can we learn from data? So it could be data from the electronic health record or EHR or from claims database. How can we learn, build new models, whether or not they're predictive models or other types of models? And then how do we put that back into practice so they can hopefully improve patient care? And so what we spent a lot of time with is on really the right, I guess the left side of the diagram, so the data. And so in the context of NCHATS projects, a lot of what our initial discussions have been on is how do we get data? So how do we get data from the EHR, from claims databases? How do we manage that data? And then how do we analyze that data and kind of take it to use the methods that Ted and Rich just talked about? And so a lot that goes into it is thinking about how can we protect the data as we're thinking about accessing it and sharing it, within projects. And think about things like ethical, legal, and social implications. And so, in our initial conversations, we thought a lot about this. And so we thought the topic of research data governance, which is really relevant to that, how do we kind of deal with the data and some of those initial questions before we can do the interesting analyses, how do we actually govern the data? And so we thought that would be a great topic for this webinar. And so Karen will actually be talking about giving us an introduction to what research data governance is, why it's important, and what's involved.
It's my pleasure to address you today about research data governance. This will be a brief introduction, akin to a brief history of time by Dr. Stephen Hawking, though definitely not as in-depth. When we finish today, I hope you will be able to articulate what data governance is. And I hope you will begin to internalize why it is important. I hope you have a hint of how you might go about implementing data governance in your organizations. And we're going to end with a few examples. So what is data governance? A very simple definition would be data governance includes the policies, procedures, and standards that maintain data security, promote accuracy, and availability. So we can talk about 4 pillars of data governance. These pillars have a foundation of people, process, and technology. Without any one of these elements, you have a very weak and unusable data governance model. The 4 pillars of data governance are data quality, data stewardship, data protection and compliance, and data management. So let's drill down on these pillars for a moment. When we speak of data quality, we're talking about the accuracy of the data. Are the data complete? Are they consistent? Is it timely data? Data stewardship involves who is accountable and who is responsible for maintaining and managing all the data assets. Data protection and compliance would include security controls, methods of encryption, management of access to the data, classification of the data into different levels to protect the data and also ensure compliance with relevant regulations. Some people will say there are 5 pillars of data governance. I'm sure there are some that say, well, there was 6. Sometimes data access management is pulled out as data use and availability. When we speak of data management, we ask questions about how do we integrate data from multiple sources? What kind of architecture do we want to use for our data? How are we going to model it? Where are we going to store it? And for how long? What do we do when we don't want to retain it anymore? A whole life cycle of data management. Let's talk a little bit more specifically about research data governance, which of course shares all of the principles of universal data governance. But there's some things in particular. These may sound very familiar to you. Human subjects protection training, the IRB, the GDPR, HIPAA, data use agreements, and the NIH data management and sharing policy. All these elements are to promote the legal and ethical stewardship of protected health information. We can never forget that we are working with information about real people who may be your neighbor, my grandmother, anyone else we care about. When we look at research data governance, certainly we want to ensure that the data are secure. We're very interested in being able to use advanced analytics, as in other industries. We want to make sure the data are accurate and reliable, and we want to promote technological efficiencies so that we can easily work with the data once we have access. We need to uphold ethical standards and maintain regulatory compliance. Data governance also enhances collaboration and supports the practice of open science. It helps facilitate reproducibility of research and certainly will maximize the credibility of your research findings. And I would like to thank IBM, wherever you are, for creating this great visual, because I was really struggling to put something like this together. We're going to talk about implementing data governance and the different phases and how each phase relies on people, process, and technology. So in the strategy and planning phase, we want to make sure we engage all stakeholders. In fact, throughout all phases, continue to engage those stakeholders. But we want everyone at the table to establish a framework for data governance. What is the scope that we're going to address? We have to be careful when we're just starting not to bite off more than we can chew, and that is so easy to do because every aspect of data governance is important. Very, very difficult to put them in a priority order. You may end up putting them in an order of what is doable right now. So what are the goals of this effort toward building data governance? What are our objectives? What are the key performance indicators that we can monitor and report to show that what we have implemented is effective? And we cannot underestimate the value of a strong implementation strategy. Data governance is a shared responsibility. People from all parts of your organization with all backgrounds should be involved as stakeholders. people outside of your organization should be involved as stakeholders. So when it comes time to design and build our strategy, we need to focus on policies and standards. And it seems easy to think about putting policies and standards into place because some things, they just seem to be right. But in our experience, getting all the parties to agree to the policies and standards is an effort. Again, engage all your stakeholders early in the process. Data management processes and procedures, they involve people and technology, certainly process. What do we want to do? What is our goal? What can we do? The technology solutions that are available today may dictate what policies, procedures, and processes we put into place. In 5 years, in 10 years, there may be other technology solutions. What are the metrics that we are going to monitor? What are the metrics that we are going to report? Are we going to report them to only immediate members of the implementation effort or all stakeholders? Or are we going to report more widely to show that we are implementing a data governance plan that will ensure that when you come to use our data, you can trust it and you can trust using it for your research? So now it's time to deliver and measure. Now, of course, those 2 slides did not take very long. The process of getting to this point could take months, could take years. Again, I encourage everyone not to bite off more than you can chew. Start small and doable, because this is a continuous quality improvement endeavor. So we implement according to plan. We have an implementation plan, and we implement according to the plan. That way, we can monitor those key performance indicators. We need to engage everyone involved, our stakeholders, everyone involved in implementing technology solutions, in putting processes into place and monitoring those processes, in establishing those procedures and enforcing those procedures. We need to educate our end users because people are going to ask, why all of a sudden do I need to do this, that, and the other? Again, we have internalized why data governance is important, and we need to educate our colleagues and the wider research community. Keep everyone informed. Do not let anything you implement come as a surprise. And be ready to provide assistance. End users are going to need assistance. Your help desk team should be fully staffed and on call and educated so that they can provide quick and reliable assistance. Now it's time to review how the implementation went. How did we perform? How did we measure up against our key performance indicators? We meet our goals and objectives. We may have had to adapt to some realities of the culture of our organization, the culture of the wider research community, we may have had to adapt to some technological realities. We might need to refine the implementation strategy. We might need to back up a little bit and refine our scope, or we may have achieved great success and we might be ready to expand the scope of our efforts. Data governance, building a data governance plan, implementing a data governance plan requires equal parts patience and persistence. Again, thank you, IBM. I want to emphasize again that this is a continuous quality improvement project like you may have never known. We move from strategizing and planning to designing and building, to delivering and measuring and refining and expanding, and then back to strategizing. Very much like the learning health model. We gather data, we analyze the data, we see where it's leading us, we implement something new. People, process, and technology are integral to this implementation. One without the others, or two without the one, will not be effective. So let's move on to some examples. Here's an example with which I am very familiar, the Unified Research Data Sharing and Access Initiative at Brown University with Advanced Rhode Island CTR and the Brown Center for Biomedical Informatics. We have developed a journey map, the top part of the diagram here, to help researchers navigate data access with all the governance processes and procedures that have been put into place. We encourage them, before they ask for what they think they want, to clearly define their research question and their population and cohort, and gain some understanding of the data source. And we work with them to create a data specification. We also educate them that there may be an IRB protocol that needs to be, submitted for approval or exemption. There are data use agreements involved. There are different computing environments for different levels of data. Data that includes PHI is stored in a highly secure computing environment. Do we need to de-identify data? Will the data be transferred from one organization to another, or one part of the same organization to another part? Have you created your data management and sharing plan? So we help researchers move through all these processes and procedures, and even when it comes to disseminating findings or sharing preliminary findings outside your immediate research team, approvals from the data provider may be required. Another example that you may be familiar with is the All of Us research program. The researcher workbench is open for even public use. However, there are some, there are some processes, procedures, and governance to go through. There's a control tier that is the most secure, and you need to have a clear purpose for needing the data there. There is a registered tier that has de-identified data. The public tier has summary statistics, identity verification, research ethics training, a data use agreement. These are all required for registered tier or above. The All of Us researcher workbench leads you through the training, and lead you through the governance procedures that you'll have to follow. And all of this, of course, is backed up by a series of committees and boards. So as this is a national resource, you can imagine how many stakeholders were involved in creating not only the researcher workbench itself, but the governance for access to the data. And the final example we'll give is the National COVID Cohort Collaborative. The N3C Data Enclave, you may be familiar, was born of the pandemic. And very quickly, institutions contributed data, but even to contribute data, there were IRBs involved, data transfer agreements, and then there were many, many procedures and standards put in place so the institutions contributing data were contributing quality data. Even then, the data went through harmonization and quality processes to finally enter the enclave and excuse me, and there are 3 tiers there. There's aggregate data, de-identified, and limited data set. And each level of data has its own set of governance. There is a data access committee that will approve projects. There are IRB requirements for the limited data set. There's a code of conduct, there's training. Again, this diagram does not show the committees and the boards that are involved in the creation of this governance and technological structure, but there are many. So I will end this very, very brief introduction to data governance. We could spend days, weeks talking about any single one of the elements. Here are a few references that you can access to delve a little deeper. And I think that's it. I will turn it back over to Liz.
Great, thanks so much. Yeah, hopefully that's been helpful to hear about, just the beginning of what research, about research data governance. Hopefully it was helpful to also hear a little bit about what the Workstream does. And in terms of, we have some time for Q&A, but just in terms of contact, feel free to reach out to us. Our contact information is here on the left. If you are part of NCHATS, one of the NCHATS projects, you can also sign up for office hours with us. So there's a QR code and a link there. I think we're all happy to kind of take any questions and also hear from you afterwards about what we've talked about today.